Hello everybody. Today we are going to discuss rhabdomyolysis induced kidney injury. This was the also question which was asked in DRNB critical care exam December 2022. So rhabdomyolysis is the literally dissolution of the skeletal muscle, and it is characterized by the leakage of muscle cell content including electrolytes, myoglobin and other sarcoplasmic protein like creatinine kinase, aldolase, lactate dehydrogenase, alanine aminotransferase, aspartate aminotransferase into circulation. Massive necrosis, which is manifested as limb weakness, myalgia, swelling, commonly gross pigmenturia without hematuria, is the common denominator of both traumatic and non-traumatic rhabdomyolysis. So, acute kidney injury is the potential complication of severe rhabdomyolysis, regardless of whether rhabdomyolysis is the result of trauma or some other cause, and the prognosis is substantially worse if renal failure develops. In contrast, in less severe form of rhabdomyolysis or in case of chronic and intermittent muscle destruction, a condition sometimes called as hypercemia, and the patient usually presents with few symptoms and no renal failure. So we review the pathophysiological characteristic and management of acute kidney injury associated with rhabdomyolysis in this discussion. So what are the common causes? So first category, so there are two causes like trauma and non-traumatic injury. In case of trauma, the commonly reported cause is the crush syndrome. Then exertion. The strenuous exercise, seizure, alcohol withdrawal syndrome, or a syndrome is may cause the rhabdomyolysis. Then muscle hypoxia. Limb decompression by the head and torso during prolonged immobilization or loss of consciousness, major artery occlusion. Then some genetic defects may result into rhabdomyolysis like disorder of glycolysis, gluconeogenesis, including phosphorylase, phosphofructokinase, phosphoryl kinase, and phosphoryl acetate kinase. Then disorder of the lipid metabolism, including carnitine palmitol transferase, long chain acetylcholine dehydrogenase, short chain L3 hydroxyacyl coenzyme dehydrogenase, then mitochondrial disorder, including succinate dehydrogenase, cytochrome C oxidase, coenzyme Q10 pentose phosphatase pathway, G6PD dehydrogenase, then purine nucleoside cycle like monoadenyl deaminase. Then certain infection like influenza A, influenza B, Coxsackie virus, Epstein-Barr virus, primary human immunodeficiency virus, Legionella species, Streptococcus pyogen, Staphylococcus aureus, and Clostridium. Then some heat disorders like heat stroke, malignant hyperthermia, malignant neuroleptic syndrome, and hypothermia. And some electrolyte disorders like hypokalemia, hypophosphatemia, hypocalcemia, non-ketotic hyperosmolar condition, and diabetic ketoacidosis. Some lipids, some drugs, and toxins are also responsible for rhabdomyolysis, like lipid-lowering drugs like statin, alcohol, cocaine. So broadly, if you want to classify the rhabdomyolysis, broadly it is classified into traumatic and non-traumatic cause. Once again, I'm revising these causes. So traumatic is caused mainly because of crush injury. Non-traumatic is may occurring in exertion, muscle hypoxia like condition, genetic defect, infections, body temperature changes, metabolic and electrolyte disorder, drugs, toxins, and idiopathy. So mechanism involved in the pathogenesis of rhabdomyolysis are direct sarcolemmic injury, which may happen in the trauma, or depletion of ATP within myocyte, leading to unregulated increase in intracellular calcium. So this sarcoplasmic calcium is strictly regulated by series of pump channel and exchanger that maintains the low level of calcium when the muscle is at rest and allow the increase that is necessary for actin myosin binding and muscle contraction. So depletion of ATP impairs the function of this pump, resulting into the persistent increase in sarcoplasmic calcium that lead to persistent contraction and energy depletion and activation of calcium-dependent neutral protease and phospholipids. The result is eventual destruction of myofibrillar cytoskeletal, and membrane protein, followed by lysosomal digestion of fiber content. Ultimately, myofibrillar network breaks down, resulting in disintegration of the myocyte. In the case of patient with rhabdomyolysis caused by trauma, additional injury results from ischemia reperfusion and inflammation of neutrophils that infiltrate damaged myocytes. So, pathogenesis, the myoglobinuria occurs only in the context of rhabdomyolysis. So, what is myoglobin? Myoglobin is the dark red 17 kilodalton protein that is freely filtered by glomerulus. It enters the tubule epithelial cell through endocytosis and is metabolized. It appears in the urine only when the renal threshold of 0.5 to 1.5 mg of myoglobin per deciliter is exceeded and is grossly visible as a reddish brown urine when serum myoglobin level reached 100 mg per deciliter. Therefore, not all causes of rhabdomyolysis are associated with myoglobinuria. Although the exact mechanism by which rhabdomyolysis impairs the glomerular filtration rate are unclear, experimental evidence suggests that in intrarenal vasoconstriction, direct and ischemical tubular injury, tubular obstruction, all plays a role. So myoglobin becomes concentrated along with the renal tubule, and the process is enhanced by volume depletion and vasoconstriction. So in the acidic environment, it interacts with the Tam-Hursfall protein to form and it forms the precipitation. So tubular obstruction occurs mainly at the level of distal tubule, and direct tubular toxicity occurs mainly in the proximal tubule. So myoglobin seems to have no marked nephrotoxic effect in the tubule unless the urine is acidic. Myoglobin is the heme protein. It contains iron, ferrous oxide, which is necessary for binding molecular oxygen. However, the molecular oxygen can promote oxidation of ferrous to the ferric, thus generating hydroxyl radical. This oxidative potential is counteracted by effective intracellular antioxidant molecule. However, cellular release of myoglobin leads to the uncontrolled leakage of reactive oxygen species and free radicals causing cellular injury. It has been suggested that heme and the free iron derived hydroxyl radical are critical mediator of tubular damage owing to protective effect of deferoxime and the glutathione. More recently, it has been shown that myoglobin itself can exhibit peroxidase-like enzyme activity that leads to uncontrolled oxidation of biomolecule, lipid peroxidation, and generation of isoproteins. So, renal vasoconstriction is the characteristic effect of rhabdomyolysis-induced acute kidney injury, and it is the result of various combination of several mechanisms. So, first, intravascular volume depletion due to fluid sequestration within damaged muscle promotes homeostatic activation of renin-angiotensin system, vasopressin, and sympathetic nervous system. Second, the experimental studies have shown that there are additional vascular mediators in the reduction of the renal blood flow, including endothelin 1, thromboxane A2, tumor necrosis factor alpha, and F2 isoprostane. A deficit in the vascular nitric oxide in renal microcirculation, and they all contribute to the mediators in the reduction in the renal blood flow. So collectively, these vascular mediators appear to be locally stimulated by oxidant injury, leukocyte-mediated inflammation as a result of endothelial dysfunction that is common to the other form of kidney injury. Now, the renal manifestation of rhabdomyolysis. Patient with the acute rhabdomyolysis usually presents with the pigmented granular cast, reddish brown urine supernatant, and markedly raised serum creatinine kinase. There is no defined threshold value of serum creatinine kinase above which the risk of acute kidney injury is markedly increased. A weak correlation between peak creatinine kinase value and the incidence of acute kidney injury or peak serum creatinine has been reported. The risk of acute kidney injury in rhabdomyolysis is usually low when creatinine kinase level at admission are less than 15,000 to 20,000 per liter. Although acute kidney injury may be associated with creatinine kinase values as low as 5,000 per liter, this usually occurs when coexisting conditions like sepsis, dehydration, acidosis are present. For example, in patients with chronic myopathies, such as muscular dystrophy and inflammatory myopathies, acute kidney injury seldom develop unless superimposed event is present. So, patient with the chronic myopathies, on the other hand, may have moderately raised concentration of plasma myoglobin, but not overt myoglobinuria. So, myoglobinuria can be inferred if urine dipstick testing show positive result for the blood when there are no red cells in the sediment. This false positive result of the blood occurs because dipstick test is unable to distinguish between myoglobin and hemoglobin. The test has sensitivity of 80% for detection of rhabdomyolysis. Other causes of pigmented urine we'll discuss subsequently, but the myoglobin is the true pathogenic factor in the rhabdomyolysis-induced acute kidney injury, but is seldom measured directly in the urine or plasma. So serum myoglobin level peaks well before serum creatinine kinase level, and serum myoglobin has rapid and unpredictable metabolism, which function partly through kidney, but mainly outside the kidney. Therefore, measurement of the serum myoglobin has a low sensitivity for diagnosis of rhabdomyolysis. Now, causes and microscopic feature of red and brown. So causes are hematuria, myoglobinuria, hemoglobinuria, porphyria, bile pigment, and the food and the other drugs. So acute kidney injury associated with rhabdomyolysis often lead to more rapid increase in creatinine than the other form of acute kidney injury. However, this finding may reflect the overrepresentation of young muscular men among patients with rhabdomyolysis rather than increased creatinine or creatinine released from the injured muscle. Similarly, a low ratio of blood urea nitrogen to creatinine is often seen in patients with rhabdomyolysis. So, rhabdomyolysis induced acute kidney injury frequently causes oliguria and occasionally causes anuria. So another characteristic feature of rhabdomyolysis is the presence of low fractional excretion of sodium, reflecting the primarily preglomerular vasoconstriction and tubular occlusion rather than tubular necrosis. The fractional excretion of sodium is the measurement of percentage of filtered sodium that is excreted in the urine, and the low level in the patient with acute kidney injury is indication of relative integrity of tubular function. However, when chemic or toxic acute tubular necrosis is established, both urinary sodium and the fractional excretion of sodium are raised. Electrolyte abnormalities that occur as a result of release of chemical cellular component often accompany and determine the severity of rhabdomyolysis induced acute kidney injury. Because they may precede the acute kidney injury, electrolyte level should be measured as soon as rhabdomyolysis is diagnosed. So, electrolyte abnormalities that can occur in rhabdomyolysis include hyperkalemia, hyperphosphatemia, hyperuricemia, high anion gap metabolic acidosis, hypermagnesemia, so high level of phosphate can bind to calcium and the deposition of calcium phosphate complexes in soft tissue can occur. So why hyperphosphatemia causes hypokalemia? The mechanism is hyperphosphatemia inhibits alpha hydroxylase, thus limiting the formation of calcitrol, which is the active form of vitamin D. So hyperkalemia is the early manifestation of rhabdomyolysis, and serum potassium can occasionally reach a life-threatening level both in patients with traumatic rhabdomyolysis and those with non-traumatic rhabdomyolysis. So hyperuricemia is also usually present owing to the liberation of nucleoside from injured muscle and can contribute to the renal tubular obstruction since uric acid is insoluble and may precipitate in the acidic urine. Then hypocalcemia, it is the common complication of rhabdomyolysis and usually results from calcium entering ischemic and damage muscle cell and from precipitation of calcium phosphate, which the calcification in the necrotic muscles. So hypercalcemia associated with recovery of renal function is unique to rhabdomyolysis induced acute kidney injury, and it results from mobilization of calcium that was previously deposited in the muscle, the normalization of hyperphosphatemia, and increase in calcium. Now we'll see how to approach the management of hyperkalemia in rhabdomyolysis. Check the potassium level every 4 hours in case of rhabdomyolysis or suspected systemic toxin. Obtain ECG and check the severe manifestations like QRS interval widening, small P wave, severe arrhythmias thought to be caused by high level of potassium. Consider cardiac monitoring and admission to ICU if potassium level is higher than 6. If there are abnormalities on electrocardiogram and if rhabdomyolysis is severe with rapidly rising potassium. Check for plasma calcium level, and hypocalcemia seriously aggravates the adverse electrical effect of hyperkalemia. If the ECG shows severe irregularities, administered calcium chloride or calcium gluconate by intravenous infusion. Consider slow continuous infusion if hypocalcemia is present. Anticipate possible hyperkalemia in the late rhabdomyolysis. Do not mix the soda bicarb solution. If potassium level is higher than 6, shift the potassium into cell. Serum potassium will be lowered approximately 10 to 30 minutes after following measures are performed, and the effect will last for 2 to 6 hours. Administered insulin and glucose by means of slow intravenous push and monitor glucose with the use of fingerstick test. Administer beta 2 adrenergic agonists such as albuterol 10 to 20 mg in 4 ml of normal saline by inhalation of aerosol over 10 minutes. Do not use the single measure and combine with glucose and insulin for additive effect. Then we have to administer bicarb if the patient has acidity. This treatment may worsen the manifestation of hypocalcemia, and the efficacy is not as consistent as with insulin and glucose or albuterol. Do not use as single measure. Remove potassium from the body with the use of either resins or dialysis as indicated. The use of diuretic is optional. Administered cation exchange resins or as retention enema. Perform hemodialysis if above measure fails and if severe renal failure and severe hyperkalemia develops. Consider hemodialysis when rhabdomyolysis is associated with marked tissue breakdown and rapidly rising serum potassium level. Check serum potassium level 4 hours after hemodialysis since rebound increase can occur. Previous measure of potassium shift into cell may decrease the efficacy of hemodialysis with respect to removal of potassium. Administered loop diuretics such as furosemide, but only after patient's fluid level has been expanded. Now, regarding treatment and prevention, patient with the rhabdomyolysis that is associated with acute kidney injury usually presents with a clinical picture of volume depletion that due to the sequestration of the water into injured muscle. Therefore, main step in the managing the condition remains the early aggressive repletion of the fluid. Patient often required about 10 liters of fluid per day with amount administered depending on the severity of rhabdomyolysis. However, most, if not all, reports showed that patients in whom acute kidney injury developed had a longer delay in receiving supportive therapy than did patients in whom acute kidney injury did not develop. Therefore, aggressive volume repletion is crucial in patients with Krebs syndrome. Although the need for volume depletion is established, the composition of the fluid used for repletion remained controversial. Some investigators recommended administering sodium bicarbonate, which result in alkaline urine. Of alkaline. So why it is necessary to alkalize? Firstly, it is known that precipitation of the Tam-Hirschfeld protein myoglobin complex is increased in acidic urine. Second, alkalinization inhibits the reduction, oxidation cycling of myoglobin and lipid peroxidation in rhabdomyolysis, thus ameliorating tubular injury. Third, it has been shown that metmyoglobin increase the vasoconstriction only in acidic medium in the isolated perfused kidney. So the principal and probably the only disadvantage of alkalinization is the reduction in the ionized calcium, which can exacerbate the symptoms of initial hypocalcemic phase of rhabdomyolysis. So the clinical benefit of alkalinization as compared to simple volume repletion are not firmly established. In one study, the renal outcome did not differ significantly between patients treated with bicarbonate plus mannitol and those treated with saline alone. Although the peak serum creatinine kinase value were below 5,000 per liter, a finding indicating that a degree of injury was mild, making treatment effect difficult to appreciate. In large study of patients who had undergone trauma, rhabdomyolysis developed in 85% of patients, and administration of bicarbonate plus mannitol did not prevent renal failure, the need of dialysis or death in sample as a whole, although the results suggested that it might be beneficial in patients with peak creatinine kinase values of more than 30,000 per liter. In randomized prospective trial of fluid depletion with Ringer's lactate as compared with normal saline in patients with rhabdomyolysis attributed to doxylamine intoxication, 28 patients were randomly assigned to receive one of the solutions. And soda bicarb was added in both groups if the urine pH was less than 6.5 after 12 hours of aggressive volume resuscitation. So peak creatinine kinase were less than 10,000 per liter, and it appears that acute kidney injury did not develop in any of the group. So the consistent benefit of urine alkalinization in patients with rhabdomyolysis, there is evidence that massive infusion of normal saline alone can contribute to metabolic acidosis, mainly owing to dilution of serum bicarbonate with a solution relatively high in chloride ion, generally generating hyperchloremic metabolic acidosis with observed reduction in the serum pH of as much as 3 units. Therefore, administration of both sodium normal saline and sodium bicarbonate seem to be reasonable approach when fluid is being replenished in patient with rhabdomyolysis, especially patient with metabolic acidosis. If sodium bicarbonate is used, urine pH and the serum bicarbonate calcium potassium level should be monitored. And if urine pH do not rise after 4 to 6 hours of treatment, or if symptomatic hypocalcemia develop, alkalinization should be discontinued and hydration continued with normal saline. The use of diuretic remains controversial, but it is clear that it should be restricted to patients in whom fluid repletion has been achieved. Now, mannitol have benefit as an osmotic diuretic. It increases urinary flow, flushing of necrotic agent through renal tubule, an osmotic agent. It creates a gradient that exits the fluid that has accumulated in the injured muscle, thus improves hypovolemia. Finally, it is a free radical scavenger. So most data on the action of mannitol come from the studies in animal, which collectively show that protective effect of the mannitol may be attributable to its osmotic diuretic action rather than the other mechanisms. No randomized controlled trial has supported the evidence-based use of mannitol, and some clinical studies suggest the no clinical benefit. So in addition, high accumulated doses of mannitol like more than 200 gram per day or accumulated dose of less more than 800 gram has been associated with acute kidney injury due to renal vasoconstriction and tubular toxicity, and the condition is known as osmotic nephrosis. However, many experts continue to suggest that mannitol should be used to prevent and treat rhabdomyolysis-induced acute kidney injury and relieve compartmental pressure. During the time mannitol is being administered, plasma osmolarity and osmolar gap should be monitored frequently, and therapy is discontinued if adequate diuresis is not achieved, and if osmolar gap rises above 55 mmol per kg. Now about the loop diuretic. Loop diuretics also increase the urine flow and may decrease the risk of myoglobin precipitation, but no study has shown clear benefit in patients with rhabdomyolysis. Therefore, loop diuretics in rhabdomyolysis induce the acute kidney injury should be used in same manner as that recommended in acute kidney injury, that is due to other causes. The electrolyte abnormalities associated with rhabdomyolysis induced acute kidney injury must be treated promptly. The correction of hyperkalemia, which occurs very early in the course of disease, is especially important. And the and that we have discussed that has been already discussed, so I'm not repeating here. The In contrast, the early hypocalcemia should not be treated under. So, what I want to say is the hyperkalemia is emergency, and we should treat it as early as possible. But in treating hypocalcemia, don't be in so much hurry to treat it because unless it is symptomatic or unless the severe hyperkalemia is present. So calcium containing chelator should be used with caution if to treat hyperphosphatemia, since calcium load could increase the precipitation of calcium phosphate in injured muscle. When acute kidney injury is severe enough to produce refractory hyperkalemia, acidosis, volume overload, renal replacement therapy is indicated, principally with intermittent hemodialysis, which can correct electrolyte abnormalities rapidly and efficiently. So conventional hemodialysis does not remove myoglobin effectively owing to the size of protein and is therefore usually mandated by the renal indications. However, owing to the pathogenic role of myoglobin in rhabdomyolysis induced acute kidney injury, preventive extracorporeal elimination has been studied. Although plasmapheresis has been shown to have no effect on the outcome or myoglobin burden of the kidney, continuous veno-venous hemofiltration and hemodifiltration has shown some efficacy in removing myoglobin, principally the use of super high flux filter and high volume of ultrafiltration. However, the evidence is mainly from the isolated case report and the effect on outcomes unknown. In addition, some studies have shown that half-life of serum myoglobin does not differ significantly between patients who are treated conservatively and those who receive continuous veno-venous hemofiltration until randomized studies are performed and preventive hemofiltration cannot be recommended. The use of antioxidant free radical scavenger may be justified in the treatment or prevention of myoglobinuric acute kidney injury, as suggested by small case series, case report, and various experimental studies of myoglobinuria, but control studies evaluating the efficacy are lacking. So these are the steps in the prevention and the treatment of rhabdomyolysis induced acute kidney injury. So first we need to check for the extracellular volume status, central venous pressure and urine output. Then measure the serum creatinine kinase and measurement of other muscle enzymes like myoglobin, aldolase, lactate dehydrogenase, alanine amino transferase and aspartate amino transferase, which adds little information relevant to the diagnosis and management. Then measure the levels of plasma and urine creatinine, potassium and sodium, blood urea nitrogen, total and ionized calcium, magnesium, phosphorus, uric acid, and albumin, and evaluate acid-base status, blood cell count, and coagulation. Then perform the urine dipstick test and examine the urine sediment. Initiate volume repletion with a normal saline promptly at the rate of 400 ml per hour with monitoring of clinical course of central venous pressure. Target urine output of approximately 3 ml per kg of body weight. Check serum potassium very frequently. Treat hypocalcemia only if it is symptomatic or if hyperkalemia occurs. Investigate the cause of rhabdomyolysis. Check the urine pH. If less than 6.5, alternate the each liter of normal saline with 1 liter of 5% dextrose plus 100 mmol of bicarbonate. Avoid the potassium and lactate containing solution. Consider treatment with mannitol, that is up to 200 gram per day and cumulative dose up to 800 gram. Check for plasma osmolarity and osmolar gap. Discontinue if diuresis more than 20 ml per hour is not established. Maintain the volume repletion until myoglobinuria is clear. Consider renal replacement therapy if there is resistant hyperkalemia of more than 6.5, that is symptomatic. Rapidly raise the serum potassium. Oliguria, that is less than 0.5 ml per urine per kg for 12 hours. Anuria, volume overload, and resistant metabolic acidosis is there. Thank you, guys.